Ladies and gentlemen, please welcome Grantmakers in Health President and Chief Executive Officer, Kara James.
Hello, and welcome back to our final session of the conference, Embedding Rural Issues in Equity Conversations. This session today is brought to you by the Robert Wood Johnson Foundation. And we've already talked throughout the conference about the importance of talking about differing communities and the needs and the unique challenges and making sure that we don't develop one-size-fits-all solutions. And it's why I'm thrilled that we're ending with the best for last. And to help us with this conversation, I'd like to introduce our moderator for this, Senator Bill Frist. Senator William Frist is the founding partner of Frist Cressey Ventures and chairman of the Executive Council of the health service investment firm Cressey and Company. He is also the founder and chairman of the Community Health Collaborative Nashville Health and co-founder of Aspire Health, the nation's largest non-hospice community-based palliative care company. As a U.S. Senator, Frist responded to representing Tennessee, from 1994 to 2006, and Majority Leader of the Senate from 2003 until his retirement. His leadership was instrumental in the passage of the 2003 Medicare Modernization Act and established Medicare Advantage. Senator Frist is a graduate of Princeton University and Harvard Medical School and completed surgical training at Massachusetts General Hospital and Stanford and is board certified in both general and heart surgery. He has performed over 150 heart and lung transplants, authored more than 100 peer-reviewed medical articles, and continues to serve as an adjunct professor of surgery at Vanderbilt University School of Medicine. In 2019, Senator Frist launched a Second Opinion podcast, which addresses challenging healthcare issues of today. And I had the pleasure of being one of his guests on the final day of a 3-day road trip across Tennessee for rural health. Dr. Frist and his wife Tracy live on a farm in Franklin, Tennessee. Welcome, Senator Frist.
Kara, thanks for that wonderful introduction. And what an exciting time it's been, really the last several days together, but today to be able to close out our annual Grantmakers in Health Conference. Indeed, it's really been a rich 3 days of discussion, during which a whole number of the unique challenges that rural and tribal communities face, and we've talked about them, they've emerged, and it's been a fantastic period of time. I'm especially excited about this conversation now with Dr. Tim Putnam and Deputy Undersecretary Justin Maxson, as we place this sort of deeper focus, going a little bit further, a little bit deeper on the rural health themes that we've all been exploring. So let's jump right in, and for the next 45 or 50 minutes, we'll be happy to take your questions here as we go through as well. And Tim, let's start with you. You are truly an expert in rural health. You have firsthand experience leading a tremendously successful non-urban health system. You've served as president of the National Rural Health Association. So let's just set the stage for us. Why are we seeing hospital closures? Why are we seeing the poor outcomes, or the poorer health outcomes? So why the provider shortages? And I go ahead and take the opportunity and help us with 2, 3, or 4 of the big barriers to high quality, accessible rural healthcare, the sort of healthcare we should all expect.
Well, I appreciate the opportunity to speak today, and thank you for the questions. I really, to get down to the nuts and bolts of it, some of it has been what's happened economically in rural America over the past 12 years. Rural America did not recover from the Great Recession. The jobs that were lost in rural areas came back, but they came back in urban areas. So a lot of the businesses that closed stayed closed. And I think that's created a real problem in rural healthcare delivery. A couple of other reasons I think have been that the payment models have really not been designed to be able to be functional in rural America. They're urban-based and volume-based payment systems that just don't work in rural areas. The other thing, I guess, would probably be regulations. Many times you get well-meaning people that are experts in their field, but they don't understand the complications and the issues and the challenges and limitations. I mean, they're well-intentioned, but if you don't live in Boston or Philadelphia or Atlanta or Washington, D.C., they just will not work in rural America. And we've seen that time and time again as these smaller hospitals in rural areas just struggle to survive. We see it in hospitals, we see it in EMS services across the nation. I think the final of the 3 or 4 challenges would be personnel. How do you get good people, good leaders, good physicians and nurses to go into rural communities and stay there? How do you get them to be successful? One of the things that we know is for a physician to be successful in a rural community, they've got to have longevity. They can't just come in for a few years and leave. Same for leaders. CEOs at hospitals typically only stay 2 to 3 years in a rural community. And it's just not enough time to gain trust in the community and get traction. So I think those are the things that we're seeing make it difficult for the rural communities to adapt to the changes and become successful.
Yeah, Tim is just playing on that a little bit further on the payment mechanisms. And we've, all been experimenting with payment mechanisms. And you mentioned that the traditional fee-for-service mechanism doesn't really adequately address the needs of communities. In this overall movement across America of moving to more value-based type care in terms of reimbursement, are we going to see an improvement with that move from fee-for-service to value? Slow to come to rural areas, but will it actually improve care, you think?
I do. I think when you look at what we do in rural areas, the transition of value is something we're excited about. Now, the payment models don't exist for it yet. I mean, we always talk about it and we think it's a great idea, but part of the transition to value is moving upstream, preventative care, and no offense, less surgical care. And can we prevent diseases from moving forward? So if you look at a rural community hospital, our focus is always about how do we improve the health of the community. We're primary care focused, much more than advanced technology focused. It's more likely you go into a rural hospital and the chief of staff is a family physician who's interested in preventing disease much more than the complex aspect of treating it. So I think rural America is well positioned for that transition to volume, from volume to value, because we don't have the volume, but we can create that upstream move. It's just getting the payment models to work.
Yeah, and I think the culture, and we'll come back to this in the next 45 minutes or so about the cultural importance of adaptation, especially with payment models. Justin, let's turn to the USDA. You're with the U.S. Department of Agriculture, and Tim just touched upon the fact that good rural health is a lot more than just having doctors or having nurses or having hospitals or facilities. It's more complicated than that. We've got jobs, we've got economic opportunities, we got housing, we have food, a lot of non-medical, we call them social determinants, but really the non-medical determinants. Just do some ground setting for us in terms of how the USDA engages in rural areas and how it specifically is impacting health.
Sure, I'm glad to. I'm extremely glad to be here. Appreciate the opportunity. It's such an important set of issues to talk through, and there are no easy answers. First thing I should say is I work in the rural development part of the department. So in some ways, we're really an infrastructure bank. Our goals are about advancing rural prosperity by trying to invest more in resilient rural infrastructure and businesses. So that includes housing, which we obviously think is the foundation of a family's health and is a large contributor to the economy. Just to give you a sense of scale, in 2020, we did about 25 billion in direct loans and guarantees to more than 100 and about 50,000 families. We invest in small businesses. We believe that economic health is critical to rural health. So we invested about $2 billion in 2020 to about 3,000 small businesses. We also, and perhaps these areas are a little bit more directly related to health, we invest a lot in community facilities like health clinics and hospitals and fire stations, those publicly owned, often a structure that supports the provision of a community service. In 2020, we did about $1.5 billion in grants and loans and guarantees. About half that actually was health related. We also have the part of USDA that does rural broadband. And of course, the pandemic clearly underlined for all of us just how broadband is a necessity, right? It's not a luxury. In particular, we do a lot of distance learning and telemedicine support, largely through grants aimed at helping communities have access to the equipment that they need in addition to broadband.
Yeah.
We're particularly aware of broadband speeds and just how important it is to recognize that so many communities, if they do have access to broadband, often the speeds aren't high enough or affordable enough to provide the level of care that folks need. And then just the last thing I'll say there, obviously the department does a lot of work on food, both nutrition security and a healthy food system. And we're spending a lot of time right now thinking about how can we transform the national food system into one that's a more resilient system that ensures that local and regional food systems can provide access to affordable and healthy food. There was just an announcement that the Secretary made as part of the American Recovery Plan. We plan to invest about $4 billion over the summer and then to the fall in attempting to revamp the food system.
On the connectivity issue, and we've talked about it in the last several days, but the connectivity issue, which is a big issue in health, as you mentioned, what department in our federal government is most responsible for that? If I'm sitting in Sinking Creek, Virginia, rural area, and we're not getting very good broadband, and I say, look up at the federal government in Washington, D.C., kind of confusing. Who does the most work there? Who's most responsible for that?
Well, if it's rural broadband, it's probably us. So we have a set of broadband programs that are particularly designed to support rural communities, have often a large grant component. There's a new provision called the Reconnect program that I think a lot of communities appreciate. The FCC has a large responsibility for broadband. Some of that has a rural component as well. And the NTIA, the National Telecommunications Infrastructure Administration, is the third. What I will say, to be clear, I've only been in government for about 4 months in this role, is that there's a lot of work to ensure good coordination between those three agencies. So I think whichever door you come through, there's a real effort to make sure you get to the right place, even if that's in a different agency.
Anything else in either the CARES Act or in the budget that you didn't mention in terms of the things that would specifically have an impact on rural areas?
Yes, sir. There's quite in the American Rescue Plan, which was the bill passed in February. There was a $500 million emergency grant program to help specifically rural hospitals and health clinics expand their access to the vaccines and food assistance, and just to strengthen the rural healthcare infrastructure. So this is through our community facilities program, and it's $500 million in grant funds aimed at helping strengthen the infrastructure of rural healthcare. We're working hard to roll that program out now. We expect it to be available in September. And it's a real opportunity to help both address the economic challenges that the healthcare infrastructure has experienced over the last several years. But there's a chunk of that we want to make sure is transformative, in the sense that clinics that come to us or hospitals that come to us with ideas of a new a service that they want to provide, or a new aspect of their operations, that a chunk of those resources can be an investment in the future that allow them to do things that they can't do now.
Tim, let me come back to you, and I'll stay away from making this a political conversation, but we have to touch upon some of the things, and I'm going to take you to Medicaid expansion. I was last in government, which I loved. I was there for 12 years in Washington in the United States Senate, and it's been 14 years since I was there. But we're seeing a clear political divide between rural areas and urban areas. A lot of differences that we probably share. I know everybody listening to us and watching us share on what the appropriate role of government is in healthcare. But if you look, I'm right now in Tennessee, and we're among the 12 states that have yet to expand Medicaid as part of the Affordable Care Act. Generally, these states are red. They're generally right-leaning states, and generally states with huge rural populations. Take that as the opening and shed some light on the perspectives and why there seems to be this sort of growing us versus them sentiment out there today.
I think there's a couple of things you can look at. One is really what's happened to rural America in the last 14, 15 years, and how desperate it's really become. To a point, you can think back of promises made to people, will bring coal jobs back, and rural America was getting excited about that. Now, I don't know how many of you worked in a coal mine, but it's not the most glamorous job you can have. So how difficult things must be for people to get excited about that as a possibility. It gives you an idea of how much of a challenge they're facing. They've seen their high schools close, they've seen their hospitals close. We've got a hospital that closes every 3 weeks in rural America. So it's really a challenge. I think those people have fanned those flames of anger in rural areas. I think to solve the issues like the Medicaid expansion, it can't be a top down from Washington. Rural America is filled with rugged individualists. They don't want help from Washington. They want to be heard. They want to have their ideas come forward. And I think if you look in Indiana, we've got a good example of that. There's a well-documented story of how then Governor Mike Pence and President Barack Obama came together in a way to expand Medicaid in the Indiana way. And it was expanded just in a time. And many of you are familiar with the Scott County or Austin, Indiana story, where a town of 4,000 people had 200 HIV positive folks before we even knew it. And very few of them had access to health care. So that was a public health crisis. And the best solution was to expand Medicaid, get them the care they need, and stop the spread of the disease. And that was able to be worked out between Governor Pence and President Obama. And if that can happen, we can do it other ways, but you've got to be able to work together. It's got to be a two-way communication. And I think there are solutions along that way, but it's been a while since that meeting's taken place. There have been changes in Washington. But I hope we get back to that point where we can have a discussion and solve issues we all want to solve together.
Yeah, no, I think it's very well said. And I think we can get back to it. I think it begins almost exactly what you said with conversations like we're having now, conversations like you described there in Indiana as well, of people coming together. And a lot of it is storytelling. It's how one tells the story. It is the representation of that story and putting it into context. And whether they be rural or people with disabilities or people of color, one of the challenges that many small populations have is being able to tell their story, to tell it in a way that it's understood, and sometimes finding the data to back up the stories, the anecdotes, what they're talking about. And this can lead to a lack of awareness, a lack of understanding, a lack of empathy on the part of others, either those listening or those who are trying to tell the story. And to either one of you, to what extent do you think there's an issue, this is an issue for rural communities, and what role is the media specifically, or the lack of local media as things have gotten more concentrated in terms of media in urban areas? You know, what role is it all this playing and the inability to tell the rural stories and experiences, which typically are so unique? And how can we do a better job in telling the story of rural America? Either one of you, just jump in.
I do think it's a problem. And I mean, I think there's a lot of drive-by reporting that isn't based in a deep understanding or in relationships or time spent in communities. I mean, you know, I think rural America actually is diverse. It's racially diverse, it's economically diverse, it's industrially diverse. And we often only hear stories about the economic distress, and we rarely hear stories about the assets and the opportunities. It is true, all of the trends have headed in the wrong direction, but I spend a lot of time in rural America, and there are a lot of assets. And part of what I think we have to do is remind, well, I'll say ourselves occasionally, but the rest of the country, how important rural America is, that our food, our fiber, our natural resources, much of our energy are stored by rural communities, and those are critical assets. But we don't get enough reporting about the opportunities and assets, partially because I don't think there's enough investment in the work it takes to build a cultural competency, to invest in the relationships, to grow connections to, I think, local organizations that can help either philanthropies that aren't from those communities or reporters get a more a nuanced and complicated understanding of actually what's going on in these communities.
I think the loss of local media, I mean, we've all seen it in small town America. We've lost our newspapers, we've lost our radio stations. The radio stations are there, but they're just playing pre-programmed music. We don't have the ability to tell our stories, and we're storytellers. I mean, that is what rural America is. Well, you know, I'll get to a point eventually, but you got to hear my story. You got to understand me. And we like that. And I think we're missing some of the successes. There are successes out there in rural America, but one thing, Senator, I know you and your colleagues know, you're trained in a medical school in an urban environment, you're trained in a residency program in an urban environment, and you're not trained how to work in a rural environment, even if you're a primary care physician. And it's just a different deal. So the lack of knowing what it's like and the lack of understanding creates this real void. And so if a position opens up in a town you'd like to live in, but you don't know how to practice in a small community without every specialist on call, how do you do that? But the people that get exposure to that understand what's going on, that feel welcome in a rural community, and that's a little bit of our challenge, sometimes welcoming people in, they find it very rewarding, but it's breaking that barrier that can be tough.
Justin, let's come back to the media and the discussion. And I'm even interested in what social media is doing. I spent a lot of time in rural Appalachia, and you know, I'm many times surprised that Facebook is used as broadly as it is.
People love it. Yeah.
The connectivity that is there, and we didn't have cell phone coverage initially, and this is in Southwest Virginia or Southwest Virginia on the border of West Virginia. We didn't have cell phone coverage, but everybody was using social media on their cell phones. That we didn't have cell phone coverage within 2 miles where we lived, but people had cell phone coverage around, but no Wi-Fi. but amazed in terms of the social media and the impact that it did have in a very positive way of people telling the stories one to the other. And then the challenge comes as to how you get those stories out to either mainstream media or people in urban areas or the decision makers. And we can come back to that, but I love the response of both of you on the importance of the storytelling. And that's what rural America is. We know that it's come from our ancestry and been passed down. Let me turn. It's so frustrating because we have so little time in terms of covering these really fantastic issues. Health equity. And Justin, why don't you start? The Biden administration, I think, has done a really constructive job on emphasizing health equity. I'm on the board of the Robert Wood Johnson Foundation, and we've turned our whole mission in many ways around health equity. But in many equity discussions, rural populations seem to not rise to the top, sometimes even neglected. How do we engage everyone in these conversations so they think of equity beyond where a lot of people start? Be very important, obviously, the racial justice term, and there are so many other areas of diversity and equity that are discussed, but rural doesn't rise to the top in so many cases. Justin, why don't you take that, and then Tim, I know you've been on Biden's COVID-19 Health Equity Task Force. So I'd love to hear your comments as well. Justin?
Gosh, I wish I had a super answer here, and I don't. I mean, I will say clearly the president recognizes both that racial equity and spatial equity are super important. His equity executive order, it named racial equity, but it also named spatial equity, and just it recognizes that rural America has faced historical disinvestment, and we have to figure out strategies that right that. And I've appreciated his balanced focus on both. I mean, the first thing to recognize is, 20% of rural America is people of color. And so often we think of the myth of rural America as only white, and obviously that's just not true. I think the American Rescue Plan and the American Jobs Plan both put real money into rural communities in a way that I don't think we've seen in a long, long time. Just taking broadband, and of course these are only proposals, but there's a $100 billion proposal that has bipartisan support to do everything possible to take broadband to 100% of the country. And that is a transformative investment. There are other investments in climate smart agriculture. And I think fundamentally to me, equity is really about trying to understand the challenges that communities in distress face. And in understanding the challenges that people of color face, that rural communities face, that tribal communities face, we can use that information to try to help design solutions and support those communities to be part of those solutions. There's an article that somebody wrote about curb cuts. Y'all know those in a sidewalk. A curb cut is that the part of the sidewalk that's a ramp. Those originally were won by disability rights advocates, but a curb cut, it helps everybody, right? If you are, you have a carriage with a baby in it, you're pulling a suitcase. My point is, I think policy solutions and economic solutions with an equity lens can benefit everybody. And I think that's part of the story we have to tell about equity. Equity is good for everybody, not just the initial targeted communities.
Yeah, I have to jump in and agree on that. In being part of the president's COVID Equity Task Force, There's a lot of representation of different groups, but rural was held up as one of the challenges. I think CDC's done a good job in the death by zip code data that they've cut out to show that if you look at the life expectancies in Appalachia, Mississippi Delta, and other rural areas across the country, they're much shorter than areas in an urban environment. So and that brings attention to how do we solve that? How do we look at rural as an inequitable situation, and how do we bring solutions to it? The discussion started really in earnest probably 6-7 years ago, and we're starting to talk about some of those challenges and some of those things that we can fix. Now, within rural, there's also, again, what Justin's saying about 20% being Black and brown population. Some of those folks are the most left out in our society. I mean, if you think about the LGBTQ plus community in a rural America, where a lot of the social services are delivered by a conservative Christian church, those are the support services, and those are the things. Since we don't have homeless shelters, we do not have food pantries that are run outside of the church. That's a population that sometimes does not feel welcome in a rural community. We've got to face those issues, and how do we deal with that? So there's discussions that have been happening over the last few years that have not happened before. So I'm really glad we're addressing them now and having issues like this. So proud that grant makers have looked at this as a possibility of how we look for solutions.
Just one other thought here, if I could.
Yeah, absolutely.
I think there are reasons to recognize, I think, the differences between rural communities and suburban communities and urban communities, because they aren't the same. But there are a lot of shared issues in needs. Everybody cares about healthcare. Everybody cares about economic opportunity. Everybody cares about employment and housing and finances. And there is contrast between those communities. There's also important, I think, similarities that we do a disfavor to the connections we can build those communities if we don't recognize the shared possibilities that communities have. And I think economic ties, we look a lot at regions, economic regions, and there are huge ties between rural communities and adjacent micropolitans and metropolitans. And so again, it's like there are differences, but I think we accentuate the differences to our peril, and we need to spend additional time attempting to see the connections. And I also think that helps us get over some of the cultural, those conflicts that have been so flamed over the last,
that I'll have to jump in and say this. An analogy that I use all the time is rural is not small urban. And this is, if you live in the world of healthcare, the pediatricians are always saying that about kids, but EMS always says that concept that kids are not small adults creates a lot of problems. I think we just have to look at it differently, realizing there's some differences, but what can be successful in one rural community can be successful in another. They all think they're different, they all think they're special, and they are. But how do we realize what we can take at one that can work in another? And I think that's an important message. And what might work in a suburban area may not work exactly in a rural area, but can be successful.
Let me keep moving. I appreciate everybody, our viewers and listeners, sending questions as we go, and I'm taking those questions and putting them in as we go. So keep them coming, because we love that. And I've gotten a couple of questions on the workforce, and so let's turn to workforce issues and just spend a little bit of time on that. About 20% of Americans live in rural areas, but barely 1/10 of physicians practice there.
Yep.
The federal government projects a shortage of over 20,000 primary care physicians in rural areas 3 years from now. And then there's nurses, and we talked about it a little bit in our earlier part of our discussion. The specific question that our grant maker viewers and listeners have submitted is, what is the current thinking about the best ways to strengthen the rural health workforce? Tim, why don't you start?
When it comes to physicians, I think, there's a challenge we have because everyone thinks of the Doc Hollywood Northern exposure kind of concept. We bring the New York City physician and then they work very successfully. Unfortunately, for every time that happens, there's probably 4 or 5 times that the physician cannot wait to get out of town, and everybody sees that. And that degrades the trust in the healthcare system in the local community. So I have become a big advocate and working with a lot of people across the nation of being an agrarian. How do we grow a model where we grow people from our community? Now, in a rural area, you're not going to have advanced chemistry courses. You're not going to have the advanced biology courses. So you're already behind going into your undergrad program of a chance to get into medical school. So we've partnered with a local high school, a regional medical school, the local community college, to how can we give these kids exposure and experience. We've got a mentorship program where kids that are interested in healthcare in high school come in and they spend 1 class per semester. So it ends up being 4 or 5 hours a week in the hospital. So we put them in the ER and in the OR, OB. If they're lucky, they see a delivery. And of the kids that come out of that program after a semester, 1/3 of them want nothing to do with healthcare, and they know why. 2/3 of them want to be in healthcare and they know exactly why. And now they're fired up. And now they've got connection with a physician. They've got other things that can help them get into medical school or nursing school or pharmacy school and be successful. And I think it's that. But it's agrarian in the philosophy. It's not like growing corn and beans. It is like growing an orchard or a vineyard. It just takes time. But once you have kids on that track, you've got something to look forward to. And you know it's going to be 10 years before that kid possibly comes back if they don't meet the boy or girl at school that doesn't want to come back or something like that. But there's a possibility they're coming back. And if you plant enough of those seeds, like Johnny Appleseed, you can have success. And that's what I've seen a lot of people doing. Instead of being hunter-gatherers, how can you be agrarian?
Yeah, I think it's a great point, and an audience question that has been submitted, and I'll read it because you just answered it, but I want to give you the opportunity to expand upon it. And it builds upon the concept that you're in the middle of a health system, a hospital, and how much do you get involved in the community itself? The question specifically from our listeners is, you run a rural hospital, and so much of what we're talking about in improving rural health isn't directly related to healthcare. Talk a bit more about how you work with the community and other entities to improve health outcomes. And you just started us down that road, but go ahead and take it a little further.
No, I appreciate the question. I think the leaders have to be part of the community. I cannot drive in here and do the job. They've got to see me out in the community. I'm also an EMT, and until recently, I used to run 911. So they'd see me as in the EMT uniform at the local restaurant, or unfortunately on a call in the middle of the night. You've got to be seen as one of the community, and then the conversations start happening. What's the conversation with the Food and Growers Association about how can we get fresh vegetables into the hospital? How can the hospital help us set up a farmer's market? Those are the type of things that start to pay dividends in a small community. But I can't do it if I'm just here for a couple of years, and I can't do it if I don't live in and are part of the community. I had an interview with the Wall Street Journal not long ago, and they were just so excited. During the pandemic, I got a call from the local hardware store that they had N95 masks, and they called me up to see if I wanted them, and I said sure, and I swung by and picked them up. Well, they just thought that was so quaint.
Yeah.
And well, no, George runs the hardware store. I'm in there a couple of times a week. He knew we needed him. He calls me up, so I swing by on my way to work. I mean, we help each other out. We're part of it, but you cannot be seen as a separate organization or just as a CEO fixing the stuff inside the box in your hospital. My mission is to improve the health of the community, and I can't do that by just creating a great box. So I think there are people doing that in small communities, and being very successful at it. But if you just come in to do a job, whether you're a physician or a healthcare leader, you're not going to be successful, and the community's going to suffer for it.
Yeah, Justin, I want to jump in on the workforce with you as well. In the event you have something to add for both of you, I know that our viewers are thinking, well, we've got government coming in and doing good stuff. We've got the private sector, which has its own incentives, and part of it is to stay, sustainable, stay in business coming in. And the question a lot of people are asking or thinking is what can grant makers be doing? Are there holes that we can specifically fill that in listening to the challenges we all know are there, whether it's from the cultural standpoint or the workforce standpoint, are there gaps that we can fill? So let's kind of keep coming back to that. But Justin, anything on the workforce that you might add to?
Gosh, I already went on to that other question. Let me come back to workforce.
No, you go anywhere. Go anywhere. It's a great thing about the style that we have. Take me anywhere.
Thank you. I ran a foundation for about 6 years that did grant making primarily in the rural South, and there were 2 lessons for us that made a big difference to the way we operated. One was we worked really hard to build local partnerships. So we spent a lot of time in communities with the local community foundation, the Chamber of Commerce, a local foundation, and local nonprofits. And that relationship building on the ground just gave us a much better sense of the ecosystem of organizations and their work to address the social determinants of health. And many of those were in some version of a network or a coalition. And it felt like to us, our ability to help support the right set of actors changed as we got in much more a relationship and just really better understood through our partners who were thinking about health from the standpoint of a strong economy and housing, heat, and education. The second thing I think we learned, and maybe it's 2 others, was we have to invest in the capacity of partnerships. That grants to single individual organizations don't add up. They just aren't as synergistic than if we make grants to networks, ensuring at least multiple organizations that have the shared vision are part of that work. And my sense was those 2 things transformed our grant making, particularly in communities that had this social determinant of health perspective, that they were identifying a broader set of concerns they had to address as a precondition or as a broader set of work to address health disparities. So if I were a foundation, I would try to figure out, and I'm not a local one, how to have boots on the ground and build relationships, how to invest in capacity building, and how to make sure that my grants are going to networks.
Yeah. And Tim, what about it?
Oh, I can't agree more. There's no one organization in a rural area that can win. And if you don't build a coalition, a partnership, you're not going to be successful. I was contacted by a group of young people that are forming the Rural Minority Health Coalition, and what can they do and how they go about doing it and proving it. And it was all about building bridges, getting things together. And you have to realize this is sort of what we do in rural areas. It's not about going to a fancy restaurant with nice wine and all that kind of stuff. It's about a fish fry. It's about a wiener roast or a low country boil. It's about everybody coming together, bringing what they've got, and it's forming that's really special of how to do, like with our agrarian philosophy, how to medical school, local AHEC, community college, local high school, and the hospital work together. That's where the magic happens.
We're listening and have listened over the last few days to some of the most influential and creative and innovative, impactful health focused organizations and foundations. And when they're looking to help address specifically rural health challenges, are there any other areas where they can be most impactful? And I'm thinking of things people haven't thought about, or non-traditional opportunities, things that they can support or facilitate. And I love the emphasis just on partnerships and partnering. And I think in Southwest Virginia and that sort of Appalachian part of it, one of the fun things for me, we're taking some small communities and introducing them to the grant makers in the larger cities like Roanoke, or introducing people in, an hour and a half away to the Community Foundation in Roanoke, which the Roanoke Community Foundation appreciated because they had no idea of the particular needs that were there. What else is out there in terms of opportunities or non-traditional opportunities? Justin, either you or Tim, just jump in.
I mean, I'll just throw one out. It's not non-traditional. I just think it's effective. And it actually, I think a little bit gets poo-pooed now, but I think investments in leadership development are critical in putting I think trying to put philanthropic resources into leadership development that help grow strong local leaders that have a vision, can see across issues. It's hard to imagine a better use of a dollar in a rural community in helping expose somebody to other ways of thinking, helping build their skills, helping them build relationships across issues. So it's not sexy or innovative, but it is effective.
Justin, I can't say you're right enough on that one. I think you've got good people, but they don't know how to be leaders. And I'll go back to the fact that it's not about a recipe. You can't duplicate it. You can't just find out what works. You've got to train chefs, and that's not easy to do. It's so much easier to follow a recipe than it is to become a chef. And I think, I work with the National Rural Health Association. They've got a Chief Nursing Officer and Chief Executive Officer certification program. It's a real nuts and bolts of how to make a rural community, something you're not going to learn in your master's degree, how to work with a local board, how to get your Parks and Rec department on board with what you're doing. So many things that just can't and are not taught in an academic center, but you need to know to be successful. So I think it's that. I think it's identifying and supporting welcoming communities. I think some communities want to be welcoming. They want to be, how can we welcome back kids that grew up here? How can we welcome new people in the community? And some do not. And I think it's empowering the ones that want to be welcoming, the ones that will welcome the physician that's moving to town, and how to make them feel comfortable. Heaven forbid you actually welcome the new hospital CEO to town and make them feel part of the town. And there are places that do, and then there are places that say, you ain't from around these parts. And I think there are different communities, and I think the ones that are welcoming are going to be successful, have the potential to be successful.
Here's a great question from the audience, a little bit of an extension of that, but it flips around of how grant makers should be looking and what data is needed to look that if money investment resources are made, that it's more likely to be used. And part of it is leadership, which we talked about. But the question is, what indicators demonstrate to you that a rural community can or will be successful in improving their population's health and well-being in the future? For funders looking to engage, what should they be looking for? Great question.
I think one of the things is the hospital that's looking actively to move from volume to value, that's trying to get upstream to help their community be successful in creating unique opportunities like that. I think the communities that invest in their future, the ones that think about what can we do for the kids, how do we make this a youth-friendly community? That is a real telling. If I go in and they keep their parks up, they figure out how to raise money to have a swimming pool, they do programs that make sure the foster kids are not left out, that the community takes care of the least of these. Those are the communities you want to invest in. Those are the programs you want to foster. Those are the ones that will be successful and have a chance of successful. Those are the ones you want to be part of, and you want to share their examples with other communities to encourage that type of thinking.
Justin, you have so much vast experience going beyond your government job. How would you answer that?
I'm not old enough to have vast experience. I just want to be clear. I agree with Tim. I'd also say, just like who's at the table, like I really believe that equity can show up in a lot of ways, and a community that's really thoughtful about who is at those tables, in terms of race, of gender, of position, of experience, that you can learn a lot about a community based on who is at the tables where the conversations are about the economic future. I will also say, and this one is a little harder to judge, but a community that has a vision for itself says a lot about its ability to execute it, and it says a lot about the leadership in the community, and it says a lot about what's possible. I'm going to go back real quick to the workforce conversation, if you don't mind.
Yeah.
Just a quick thought, and I know this isn't true everywhere, but at the University of Pikeville in Pike County, Kentucky, there's the Kentucky College of Osteopathic Medicine. And part of what I like about it is that they do really targeted outreach to rural kids who will go back to rural communities with those degrees. And there's just something about the location of that sort of a training facility in a community of less than 15,000 to produce healthcare professionals that go back to rural communities. And again, you can't replicate that everywhere, but I think there are examples of that should be spotlighted. And our community facilities program, from this $500 million we just got out of the ARP, those are the sorts of resources that could go into the creation of degree programs in rural communities to produce healthcare professionals to go back to rural communities.
You know, one thing I'll add to that is look for rural communities that face their challenges and don't ignore them. That's one of the things. If you've got a community that's actively trying to fight an addictions problem, you've got one that's looking to make themselves better and not just hide it. I think that's one of the things you'll find. I think every rural community's got an issue with addictions, and I think some are addressing it, and I think some are covering it up.
I love both of those points that you made. We have a couple more minutes. Justin, another question came in. I really appreciate everybody sending their questions. It's a fantastic discussion. The question is to Justin: how can funders interested in improving outcomes in rural communities engage with the USDA? You know, it's a great question, because everybody when I was in government, people would say, well, you're up there, you're in Washington, it's so far away, it's big dollars, I don't even get what you do. But how would you answer that question? I think it's a great question.
Yeah, it's a great question. I mean, the first thing I'd say is we've got about 500 offices across the country. And it's one thing if you're, the Robert Wood Johnson Foundation, but it's another if you're a local or a regional, a grant maker, to spend the time connecting to our local staff. They know the programs, they're often, they're from the community. And I think they're a great ambassador, not just to our programs, but to the federal development family. So I would ask you to, if you've not, seek out the local staff. Every state has a state director, and they're a political position, but the interesting thing about them is they're really from the place. So they'll give you both that connection up to Washington, but also within the context of that state. So I think the state directors are a real important touch point for a grant maker who wants to get involved in health or economic issues in their states.
Good.
And I'm also glad you can email me, and I'll eventually get to it, and I promise I'll get back to you.
I love it. Tim, another final question. I've got a closing question for both of you, and we'll wrap up here in about 4 minutes or so. But Tim, there's a question about virtual healthcare that's come in, and a couple of people asked it with regard to the workforce, the shortage, the lack of access, the lack of being able to make it to a hospital in those counties, increasingly with the closure of rural hospitals, of the role of telemedicine. And how realistic is it? And we've already answered part of it, or we've discussed part of it, and that is the connectivity of whether it's fiber or access or cell phone coverage itself. But Tim, you're right in the middle of it. What is the role of virtual healthcare, specifically as we address the challenges we see in rural healthcare today?
Well, a couple of examples that I'll talk about. One, it's really important. At the start of the pandemic, we already had virtual clinics in our schools. So the school nurses could connect with a primary care physician when a child presents with an issue, and they can actually do a visit, listen to breath sounds, listen to heart sounds, look in the ears and nose and throat. Those were converted over to COVID screening areas and treatment areas to keep our chronic patients away from the potential COVID patients. So phenomenal partnership with the schools that we already had in place and show the flexibility of how to use telehealth. I think the other thing is, a lot of people think about the patient receiving care on their couch, which is important, but given rural's lack of broadband is a challenge. I think there's going to be value in the primary care physician consulting with an endocrinologist, a neurologist, a pulmonologist in that primary care visit. Unfortunately, there's not payment models for that right now. But as you look at it, how to get that specialty care to keep that patient from having to travel hundreds of miles to get that care. I think things like that are solutions that we don't have models for, but certainly when I talk to primary care physicians, yes, I'd love to be able to work with this patient with the endocrinologist to get their diabetes under control or get their medication management. I see that as a real potential, but it's in a partnership, not a standalone.
But I think it is for the grant makers who are asking the question, a huge opportunity that government can come in and improve connectivity and work with the private sector in terms of getting the lines in. Doctors are willing to do it. Nurses are willing to do it. Specialists an hour away or 2 hours to 3 hours are willing to do it. But there is this gap from a reimbursement standpoint to get it started. Mm-hmm. After it's started, it's going to prove itself, I believe. And then government will step in and the payers and the insurance companies will step in. This is frustrating. We've got about 3 more minutes. And with that, I'd love to just close with a question that both of you can answer. And it's been a fascinating 3 days. And the theme of this year's conference has been building a just and equitable future. Let me ask each of you, and Tim, you can start off. Tell us what are the top things you'd recommend that we do to ensure rural communities experience what the thematic has been, a fair and just recovery.
I think it's telling the stories to communities of what you're like when you are a just, equitable, and welcoming community, and what your future is like if you're not. And I don't think they see that. I think they want to go back and do things the way they've done them before in many rural communities. It's the farm, to use a farming analogy. People that focused on trying to produce more corn and beans quit farming in the 80s. It's about adapting to what government programs, what programs Justin at the USDA has, and about what's changing. And I think the rural communities that adapt and change and become welcoming will be successful. And the ones that try and do things the way they did in the 60s when their population was at this level will fail. I hate to say that, but I think it's an opportunity to tell that story to these communities and get some of them to wake up to see their future. There's an opportunity right now where there's a little bit of movement out of urban areas into rural because of the pandemic, and you can work remotely. So there's a good opportunity to take advantage of that today.
I love it. We're all in it together, and it works both ways. Justin, how would you answer it?
Gosh, I mean, what he said.
I love it.
I would add to that just, I think foundations need to invest in capacity. And it's so easy to think about your money as only supporting a project or a building. And we got to have strong, we have to have strong rural organizations with effective leadership. And without that sort of resource, these organizations just dry up and go away. So support building capacity of strong, effective local organizations. The capacity is out there. Like, yes, there's less capacity in rural communities, but it's there. It is harder to find. And so it's worth trying to build relationships on the ground to find those organizations and make the money available. The last thing I'll say is the federal government has to make real its promise to rural America and have federal rural development policy that puts resources, real resources into these communities. And, I run a development finance bank. That's what we are. And we will not development finance our way out of the situation that this country's in. Those assets are critical. but they've got to be part of a more holistic approach to helping rebuild rural communities. So I don't exactly know how to do that, but I'm aiming at it.
The challenge is out there. You set the challenge for us all. Listen, I want to thank our audience. I'm going to flip it to Kara here in 15 seconds. But I want to thank our audience. You have led this discussion today. You've provided the questions. And Tim, thank you so much for your insight, for your perspective. And Justin, thank you for your service and your perspective on these important issues from the federal and the policy standpoint. Kara, let me throw it back to you.
Thank you so much, Senator Frist, Justin, and Tim. Wow, what a way to end the conference, and such a robust conversation that covered so many topics and challenged us in our efforts and our work ahead of us. We've covered a lot of ground these last 2 weeks, including the pre-conference workshops. We've been challenged to think about how to do things differently, since doing the same things over and over again hasn't yielded different results. We've been encouraged to start where we can and partner with communities and those most impacted, because as we know, they have a wider view on solutions and they know and are experts in the needs and opportunities. We've learned and had reinforced in this last conversation that one size doesn't fit all, and that we need to ensure that our work and our organizations reflect the diverse needs, voices, and skills of our communities and our society. And that, as Carolyn said, when we have that diversity there, they're not just there for show, but that they're respected and truly valued for their opinions, whether that be people of color, persons with disabilities, rural communities, or members of the LGBTQ community. And hopefully, we've seen that equity can be and should be in everything we do, from COVID-19 response and recovery to public health, maternal and child health, food access and security, oral health, mental health, the list goes on, because as Justin said, equity is good for everybody. And capacity is something that we need to invest in, because we're not growing corn or beans, but we're investing in an orchard or a vineyard, and that takes time, but yields great results. So I want to thank you all for joining us for our first virtual conference and for bearing with us and putting up with and overcoming the technical challenges that may have encountered. I want to thank VRS and Cheshire and the entire GIH staff for all your efforts in making this happen. I hope that you'll share your thoughts about the conference and additional topics that you'd like to see discussed in future meetings through our evaluation. And speaking of future meetings, we look forward to seeing you in person at the GIH Fall Forum in November in Washington, D.C., and at next year's annual conference in Miami. That should give us plenty of time to lose our pandemic cushions and be ready for beach weather. Until then, be well and keep in touch. Thank you.